good afternoon, or I guess good morning, depending on where you live. We're going to jump in. This is the, I guess, second module that we're going to talk about health economics. And in the first module, I introduced you to Kenneth Arrow's seminal work in healthcare, kind of driving change in the healthcare environment, and also just a high-level overview of just some information I, have, I guess, just nuanced to me that trying to give you an understanding, or at least a basic overview of what health economics is. And today I'm gonna go back, and for those of you that have had me as an instructor in class before, know that I typically at the start of each segment, or at least at the start of each chapter or new module, I like to go back and do a little refresher on what we talked about last time. And today we're going to be, I don't want to say comparing, but going to refresh everybody's understanding of Arrow's article, again, published in 1963, seminal article. People, academics especially, think it may have been the driver to huge changes in healthcare reform, or at least the way the medical care system operates, a shifting of incomes through subsidies, establishing different ways to provide medical care to a wide variety of populations. And then we're going to talk for a few minutes about Diane Dewar's textbook that we're going to use. Hers was written in 2010 and maybe a little outdated on some of the concept, but we'll take care of that as we go along. But a lot of the basic economic concepts in her book haven't changed much since she published it in 2010. So things have changed maybe in the healthcare space, or the medical care space, or the way providers are contracted, or shifting of financial risk. And again, we'll get into that as we go through the chapters. But it's not a bad text to get you an understanding of health economics and what health economics or what health economists do kind of in their day-to-day lives. But right now we're going to go back and go through this, just the high points of Arrow's article, just to make sure everybody understood what we were talking about. And so his article comes out in 1963. As I said last time, probably started writing it in the late 50s. I don't know. The publishing process in the United States in academic literature sometimes takes a while. And so it comes out in 1963, and he didn't really mention it, but the VA started providing at least a government agency to oversee VA services, started in 1930. Arrow's article comes out in 63, 1965. I think Johnson, again, was president. And so he enacted Medicare and Medicaid. In 1967, they enacted CHAMPUS, which is the healthcare program for active duty members and their families. And that kind of transitioned to what now they call TRICARE in 1995. So Arrow's article, academics will tell you, it kind of spearheaded these changes. May have to a certain extent. I'm not sure I agree with all academics, but that's their contention. And when I was in graduate school at Ohio State, it was required reading for a lot of classes. So, and his main point is, with medical care, it's uncertainty in the incidence of disease and the efficacy of treatment is what makes or what drives medical care in the United States and all over the world to a certain extent, but especially in the United States. It drives it in such a way that it is extremely difficult to function in the space, to provide analytical expertise in the space. Anybody that's ever worked in healthcare, especially on the analytics side, will tell you that the quality of the data that we have to work with as a healthcare economist is certainly not the best. It lacks a lot to be desired, but that's what we have to work with, and that's what we just have to move forward with. And I think one thing that Arrow, he kept banging on And he talks about the competitive market. And if you go back to your microeconomics classes, you'll remember that competitive market means all producers are providing homogeneous goods and services. And I guess in theory, in the healthcare space, if you look at it as a homogeneous service, if you're a hospital, most hospitals provide outpatient services and inpatient services. If you're a primary care physician, you're going to provide typically homogeneous services to everybody else that is a quote a primary care doc. If you're a pediatrician, if you're a cardiologist, to some extent they're homogeneous services. But if you've ever been to the doctor or have been exposed to issues within healthcare, you may argue with that, and I probably tend to argue that probably not the competitive model may not be the best model to use when you're looking at healthcare. There are a number of buyers and sellers, which is the basis of a competitive market. That way that theoretically buyers don't impact price, sellers don't impact price. One other thing to kind of keep in mind is health plans in a lot of areas, a lot of geographical areas, serve as the market, and the market because they bring buyers and sellers together. Again, going back to your microeconomics and information that you would have gleaned from there. One of the other assumptions of a competitive market, it's easy entry and access or exit. So I don't know. I'm not sure it's easy entry into the healthcare market. You've got American Medical Association, developing standards and credentials and accreditation. You've got the government playing in the sandbox, trying to dictate how providers function. So I'm not sure it's easy to exit. I'm not sure it's how easy it is to as far as entry. And to me, the biggest drawback, or one of the biggest drawbacks, is in a competitive market, there's complete information about prices. And in healthcare, unless you work somewhere in the healthcare space, I'm not sure that there's enough information about prices. Now, a lot of health plans, I worked at United Health a few years ago, and they had developed this little mechanism on your cell phone or your mobile device that you can go in and you can compare pricing on providers, especially if it's part of pharmaceuticals. So if you get a script, you can say, do I want to go to Costco? Do I want to go to Sam's Club? What about CVS? What about Walgreens? You can compare prices like that. You've also got those deals on your cell phone now that, you talk about GoodRx and supposedly provide information about prices, but for the most part, and I have health plan. I live in Atlanta, so my health plan's through Anthem. It's a Blue Cross Blue Shield health plan, and my copay is $10 if I go to my primary care doc. It's, I think, $35 if I go to a specialist. I think it's $35 if I go to urgent care, something like $75 if I go to the emergency room. If I go to the hospital, it's like $250 a day, maxed out at like $1,000. After that, I don't have to pay anything. So that's kind of the benefit plan that I have purchased from Anthem. But if you ask the individual on the street, or if you start asking other students or other coworkers what the cost of health care is, a lot of them will say, if they've got a copay, whatever that copay is, $5, $10, $25, they will tell you that's the cost of health care. And trust me, that is not the cost of health care. So pricing is driven for the most part either by government-based fee schedules like Medicare and Medicaid, TRICARE, VA, or it's driven by the contractual arrangements that health plans have with providers, or it could be driven by bill charges. If you're a private pay individual, you may be paying bill charges. If you don't have health care, you're going to be billed X number of dollars, and you can sometimes negotiate those prices, but for the most part, that's what you're going to be billed, and that's what individuals are going to look at as far as price. Error also says that information increases the probability to skill medical care, and that's true. The problem with it is there's a cost to information. How is the average consumer going to derive that information? They can spend hours on the internet. They can go to WebMD. They can go to some of these other websites, and they can talk about, here's my diagnosis, here's how I feel, and they'll, WebMD will spit out some potential issues that you may be facing, but there is a cost to information, and a lot of individuals just say, I don't have the time, I don't have the effort, I don't have the energy to get on the internet and look for that kind of stuff. I'm just going to go to the doctor, and whatever Dr. Smith tells me, then that's just what I'm going to go with. So that's, information is a huge driver in the healthcare space, or the lack thereof is a huge driver in the healthcare space. The issue on the provider side, so whether it's your primary care doc, your orthopod you go see when you've got a banged up knee, your ENT if you've got issues with breathing or something. So the issue for those individuals is demand is irregular, it's unpredictable, and it's risky. And we'll get into it a little more when we get into Gawar's text in a few minutes, but it is a huge issue for especially medical economists or healthcare economists to try to estimate or try to forecast or try to predict demand, because it's somewhat cyclical. You can usually say November to probably March, you're going to have issues with colds and flu-like symptoms. You can kind of predict that. If you're an OBGYN, you can predict if you have, X number of individuals in your practice, that your patients that are pregnant, and when they became pregnant, you can estimate, well, 9 months down the road, we're going to have to be doing some deliveries. If you've got, congestive heart failure, diabetes, COPD, some of those diagnoses, there is a way to use some actuarial tables to try to predict and forecast what the impact's going to be. But for a large number of providers, predicting the demand for their services, it is somewhat unpredictable. And just think back and late 2019 to March of 2020, when everybody people knew something was happening in quarter four of 2019, because of COVID was starting to creep up. It hadn't hit the United States full bore, but by March and April of 2020, it was rampant within the United States. And that, you're talking about something that threw off, the economist's ability to predict. And, that was, trying to estimate and forecast. That just turned everything upside down. So that's on the provider side. If you flip to the consumer side, product uncertainty, quality, asymmetric information. I mean, it's not like you can test drive your doctor. It's not like going out and buying you're going to buy a used car or buying a new car. You get to go in and test drive it. You go to Costco, I see people, bringing TVs and things back to Costco. They go in, they buy a TV, they test drive it. They don't like it, they bring it back and you get another model. So, it's not like you can, you have a, 30-day ability to test drive this doc. Especially if you're picking a new provider, you're going in, I don't want to say sight unseen, but for the most part, for most individuals, when my wife is trying to select a physician for us, she's looking at, where they went to medical school, did they do a residency, what was their interns, where have they been practicing before, what their specialty is, do they have a subspecialty? If it's an internal medicine guy, they have a subspecialty in cardiology. She's constantly out on the internet trying to find that information, and it's still a crapshoot. It is really difficult to beforehand, estimate the quality of the product you're going to get when you go in to see the doctor. And I worked at the hospital at Ohio State when I was in graduate school, doing financial modeling and helping them do some revenue cycle management processes and things. And one of the jokes of everybody that, working in the hospital, they laugh constantly about the old joke going around, what do you call that individual that finishes last in their medical school class? You call them doctor. And that just goes to show that if you have the perseverance and are able to get through medical school and do your internship and your residency without, causing too many issues, you're stamped as, employable as a physician, and, you're sent out into the world to provide healthcare services. It was an issue for Arrow when he wrote his article. It was an issue as you kind of read through Dewar's book. It was an issue for her book when she wrote it in, late, I guess it was published in 2010, so I'm not sure how long it took her to write it. And even if you look at healthcare now, it is the issue with consumers is, what is the product uncertainty? When you walk in that doctor's office, what do you expect? And the expectation is you expect to be treated for whatever your episode of care is and to go home and feel better. Sometimes it happens, sometimes it doesn't. And you're going to, I think we can all say that we've gone into a doctor's office and walked out of there with varying degrees of, and I'll go back to your micro class. You've come out of there with, varying degrees of, utility, satisfaction, benefit for going to the doctor's office and, because they say consuming that good and service. So it is just, it's unfortunate that healthcare is the way it was in 1963 for Arrow. I think we'll find some of the same issues as we get into Dewar's book, that again published in 2010. And then Arrow and Dewar both are going to talk about issues with, social non-market forces. You think about, your micro classes and you're talking about, market forces are going to drive the supply and demand to equilibrium. It's going to be that equilibrium price that clears the market and equates supply and demand, equates what buyers are interested in and willing to pay for, what sellers are willing to sell a product for. And again, it's, or you want to look at it as, Adam Smith's invisible hand. It's driving market forces, driving that market to an equilibrium price and an equilibrium quantity. In healthcare especially, there are social constraints or social factors that are pushing on healthcare especially, and we'll get into that as we kind of work through Dewar's book. But this is going to kind of wrap it up on the review of Arrow's article, and come back for the next session. And on our next segment, we'll get into Dewar's book and her take on what the issues are with U.S. healthcare system. Thanks for joining, and talk to you in a few minutes.